Okay, good morning to Dr. Vila, Dr. Fairuz, and all of my friends. Okay, today I would like to present about animal bites and stings, supervised by Dr. Vila. Okay. Okay, for the introduction, bites and stings are directly related to the venom, which is injected to the body. And most of the stings are not medical emergencies. However, the treatment is usually required if there is bleeding, wounds, or infection. And then these bites and stings need to be identified and treated early, as the bite can affect some part or the whole body, which can cause mild, moderate, or severe reaction, and can also be life-threatening. And the severity of the bites or stings depends on the type of creatures, the strength and amount of venom injected, and also the patient size, age, and general health. Okay, next. Okay, I'll go to the animal bites first. Then animal bites is defined as the bite of domestic or wild animal. Also included human bite, which carries risk of infection as well as soft tissue injury. And then animal bites, 90% of it is account for dog bites. And one of the most serious diseases that can result from dogs or wild animals is rabies. Rabies is considered fatal if not treated, and then medical attention needs to be given as soon as possible. And also tetanus is potentially fatal infection that affects the central nervous system. It is caused by the transmission of bacteria that produce a toxin when someone is bitten. Okay, next. Okay, thank you. Okay, regarding dog bites, dogs have rounded teeth, and the pressure exerted by the jaws can cause significant damage to the underlying tissue, including muscle, bone, tendons, and blood vessels. Okay, so regarding rabies, it is a fatal but preventable viral disease. It can spread to the people and pets if they're bitten or scratched by rabid animals. And it is transmitted through direct contact, such as through broken skin or mucous membrane in the eyes, nose, or mouth, with the saliva from the infected animals. Okay, the diagram you can see how the virus enters the tissue and then replicates near the muscle, replicates in the muscle near the bite site. The virus moves up through the peripheral nervous system, through the central nervous system, ascends through the spinal cord, reach the brain and cause fatal encephalitis. And the virus enters salivary gland and other organ of the victim. Okay, next. And the incubation period of the rabies is typically 1 to 3 months, but it could vary from less than 1 week to more than 1 year. All of this depends on the distance the virus travel to reach the central nervous system, i.e. the location of the bite. If the bite is nearer to the central nervous system, then it could cause the disease quicker. Okay, so the risk categories for rabies, there's 3 categories. Category 1, Category 2, and Category 3. So for Category 1, when we took the history, the patient will say that the wild animals or the dogs either lick, touch, or licking or touching on intact skin, meaning there's no broken skin, then there's no action need to be done. And then for category 2, if there's saliva on scratches or abrasion on the skin without bleeding, or the animals was nibbling on uncovered skin, then we need to first clean the wound and then give immediate rabies vaccination. And then for category 3, if there's a history of bites or scratches that penetrates the skin, exposure or coming in contact with the saliva at the eyes or the mouth, then we need to clean the wound, immediate rabies vaccination, and also rabies immunoglobulin. Okay, so this is the guide to post-exposure prophylaxis following the risk assessment that I mentioned before. Okay, so for category 1, which is no risk, no need for the rabies vaccination. For low risk, give 5 ampule, each 1 ml ampule of 2.5 rabies vaccine on day 0, 3, 7, and 14. For our practice, we just give day 0, day 3, and day 7. And then for high risk, give 5. We give the same for the rabies vaccine, plus the human rabies immunoglobulin within 7 days of starting the course of vaccine. And this vaccine was given via IM. Okay, next. Okay, lastly, I will touch a bit about human bites. Human bites differ from other animal bites because they may be more contaminated and tends to occur at the higher risk area of the body and often receive delayed care. Human saliva has been found to contain at least 42 different kinds of species of bacteria. However, it is not considered a risk for transmitting hepatitis B or HIV. Lepas satu je.
Start.
Okay. Okay, next we move on to animal stings. Stinging insects are limited only to the order of Hymenoptera, which includes wasps, bees, and ants. And most of the animal stings are considered not medical emergencies, but it can cause severe allergic reaction, which is the anaphylaxis, anaphylactic shock, and can cause death. So the mechanism of the spread of the venom can be spread either by circulatory, either through the blood or the lymphatic system. Hence, the only way to slow down the spread of the venom through the lymphatic system is to use pressure immobilization technique, as well as to minimize movement of the affected limb. Because of the spread through the lymphatic system, so we don't usually advise for the cut and sucking of the venom at the sting site to the general public. Okay, for general signs and symptoms, there's a local and systemic allergic reaction. For local reaction, there's a pain or itchiness at the affected site. There's a mark on the skin. There's a local redness and swelling, and also possible remnant of the insect at the site, such as the stinger, the venom sac, the tentacle, etc. For systemic allergic reaction, the patient could have shortness of breath or wheezing, tightness in the throat, hoarseness or change of voice, difficulty in speaking. Patient could have AGE symptom, nausea, vomiting, abdominal pain, and also loss of consciousness. Okay, for initial or local treatment, first we need to do is if there is a stinger at the sting site, then we need to remove it. The way to remove it is to use anything flat and scrape the stinger out of the sting site. Why? Because if we pinch the stinger or we use forceps or tweezers, we could squeeze the venom from the venom sac more into the site, and we can worsen the condition. Then we place ice pack on affected area to elevate the pain, elevate the affected limb to reduce swelling, use pressure immobilization. For pain management, we use topical or local anesthesia, and also we give anti-tetanus prophylaxis. And for systemic treatment, we need to recognize and manage anaphylaxis if present. Okay, this is a brief diagram of the signs and symptoms of anaphylaxis. First, the patient will have confusion, headache or loss of consciousness. There's a swollen eyes, swollen lips or tongue. The patient could have wheezing, cough or difficulty in getting air. There's a hives on the skin present, and also tachycardia. Okay, this is the diagram regarding how to identify the anaphylaxis. Okay, anaphylaxis is likely to occur when any of the three criteria is fulfilled. So, for one, acute onset of illness, minutes to several hours, with involvement of skin pruritus, flushing, hives or angioedema, and either respiratory compromise, where the patient have dyspnea, wheezing, or bronchospasm, stridor or hypoxemia, or reduced BP or end of organ dysfunction, such as collapse, syncope, or incontinence. Then the second criteria is two or more of the following that occurs rapidly after exposure to a likely allergen. The symptom of the skin, the sign of the skin, the pruritus, flushing, hives, and respiratory compromise, reduced BP, and organ dysfunction, and also persistent GI symptom, which is vomiting, crampy abdominal pain, and diarrhea. And let's see the criteria after the exposure to unknown allergen. For that patient, minutes to several hours is reduced blood pressure. Okay, so this algorithm of management. If patient present with possible anaphylaxis, first we need to decide if the patient is having an anaphylaxis. If no, then consider acute diagnosis. If yes, we do immediate intervention. We assess the airway, breathing, circulation. We have IV access, oxygen, and vital sign monitoring, place the patient in supine position, and we give IM epinephrine at the anterolateral thigh. Then other intervention based on initial response. If the patient has low BP, we give rapid pre-infusion. We repeat IM adrenaline if necessary. If the patient has airway compromise, bronchospasm, we give bronchodilators, steroids, and antihistamines, and we establish patient's airway. And after we have stabilized the patient, then we determine the disposition based on the patient's initial presentation and also respond to the therapy. Either we need to admit to the general ward or ICU, or we just do observation at the emergency. For observation at the emergency department, the length of observation is based on clinical presentation, response to the therapy, risk factors for fatal anaphylaxis, the patient access to medical care and reliability. And we need to give patients education, SIE use, which is the self-injecting epinephrine, the EpiPen, biophysic reaction and trigger avoidance. If we could provide homegoing SIE, and we consider the prescription for oral antihistamine and corticosteroid. Then we need to follow up for the patient, either allergies or primary care.
Bashir, in our setting, any patient who required IM adrenaline for any mode of anaphylaxis, secondary to bites, drugs, or by any reaction, like even a vaccine anaphylaxis is warranted for admission. Dia tak boleh observe sahaja, ya. We need to admit them because there is a risk of delayed hypersensitivity reaction. Okay, ya?
Okay. Okay, for lastly, for regarding IM adrenaline, it should be given immediately as it maintains blood pressure, antagonizes the effect of release of mediators, and inhibit further release of the mediator. In mild cases, we could give 0.3 to 0.5 IM. Then we repeat twice at 5 to 15 minutes interval. For major airway compromise or hypertension, it should be given 3 to 5 mils in 1 in 1,000 IV or via ETT. And we give infusion necessary, either adrenaline, 5 mg in 500 cc, either normal saline or D5 at 0.1 microgram per kg per minute. And for pediatric cases, we give IM adrenaline 10 microgram per kg or 0.01 ml per kg. The dilution is 1 in 1,000. The maximum dose is 0.1 ml into lateral thigh, which should be repeated after 5 minutes if the condition is not improving.
Okay, Bashir and the others, please don't get confused with your adrenaline. Pernah tengok tak adrenaline vial dalam department kita? Pernah anyone encountered adrenaline? Have you physically touched the vial? Pernah ke? Jawab.
Pernah.
Pernah? Kamal, Wong, pernah?
Ya, pernah, doktor.
Pernah. So that one vial contain berapa miligram?
1 milligram.
1 miligram. Berapa mil?
1 mil.
1 mil, So 1 mil, 1 milligram. So be aware when the major airway compromise is written there 3.3 to 5 mil, right? It's basically when you ambil 3 mil tu itu adalah 0.3 milligram sahaja. So I would advise you all to use a standard dosing in adult. In adult, use 0.5 milligram or 5 mil. Better not to have a range. You use 0.5 milligram. You may repeat the dose until you maintain a stability, and you may, if the patient deteriorate, you may start the patient on adrenaline infusion. Tetapi dalam PITS group, again I'm repeat, in PITS group, you need to dilute the adrenaline. It cannot be given a pure, nah. Okay, sebab tu you nampak dia punya dose pun 0.01 mil per kg. Tadi yang adult 0.1 kan? 0.3 to 0.5. So you need a further dilution. Do not give the pure in a PITS case. And PITS kindly go according to the weight of the patient. Go according to the weight of the patient. Do not give in general calculation. And maximum you can give is 0.5 mil sahaja. Okay? Thank you.
Okay, that's all. Thank you, Doktor.
Thank you. Terima kasih semua. Thank you.